All right, good afternoon, everybody. Welcome to the Marlborough Hospital Town Hall for May 22nd. We're going to start first and foremost with a quick cause for applause before we turn it over to Dr. Dickson, who's going to provide a system update for everybody at Marlborough Hospital. So I'm going to let John walk us through this next slide, if I can get there. Won't move. There we go.
All right. So thanks, everyone, for joining. We've got two great slides I just want to share with you. So this first one is for Nurses Week and National Hospital Week, and we have some pictures of all the different things we celebrate. And I just want to, thank everyone for attending these and for everyone with the help putting it together. That week we also had two Daisy Award winners. One is pictured on the left, where you can see Mickey and Ashley there on the right, as well as several other award recipients over the week. The food trucks, really a terrific week, and thanks for everyone for being part of it. And I think it was a big success, and looking forward to next year. And here's a few pictures from the service awards, and we had a great attendance this year. It's the first year we were able to do it in person again, and it was a lot of fun. We had Paul Ruggieri in the top left there, 35 years of service. Our employee with the most years of service, Sue Castelli, was 40 years. Don't see a picture of her up there, but lots of other folks, and just another terrific night that was held at the Marlborough Country Club, and lots of smiling faces and lots of good laughs. So thank you all, and congratulations to everyone on their service years. And I will now hand it over to Dr. Dickson.
Thanks, John. I'm going to try to share slides with you here if I can. And you tell me when you're seeing them.
We can see them.
Great. Well, thank you, everyone, for the opportunity to just come and say hello and hopefully answer a few questions to your town hall. Some of you may have attended the system town hall the other day. I apologize if this information is redundant, but not a lot has changed in a week in terms of the healthcare system. I know a lot of folks didn't get to make that, so I'll talk a little bit about what's going on here, starting with our last COVID update. I hope our last COVID update. As folks know, the global health emergency is over, the World Health Organization has said. The U.S. public health emergency is over, which is going to change a lot of things, and some of the waivers and flexibilities that we had through COVID. And I'm thrilled about this. Well, at the same time, I just have to think back of what you've all been through the last 3 years going through this. It was March of 2020 when we had our first surge of COVID over to the left here. And the first patient I saw with COVID, I can't remember, it was the first one in the system. I think we had some outpatient COVID first, was an ICU patient over in Marlborough Hospital that, as I recall, was not expected to live, but did quite well under your amazing care. And although that surge to the left was not the peak in terms of number of patients, it was by far the worst for us to deal with in those early days of COVID. And we managed 3 major peaks and some minor peaks, each time having to ramp up our ICU capacity, our floor capacity. Been wearing those masks for a long, long time everywhere we go. And it's so exciting that this is over for now. And I think COVID will become something like influenza, an annual pandemic, mini pandemic of sorts, where we'll have increases and decreases, and we'll probably all mask up. Frankly, we probably all should have been masking up for influenza pandemics previously. At least we've had 3 years of practice. We will, in general, allow now healthcare givers in the hospital to, if they choose, to remove their mask. Nobody has to remove their mask. In fact, I would encourage people to move their masks. I get sick every time I go on an airplane. I'm looking forward to wearing my mask when I'm on it next time I'm on a plane next week. And so I would encourage people to do the same. And I think each person has to take into consideration their own specific situation. Do you have somebody that's immunocompromised at home? For example, maybe masks continue to be the right thing for you. The emergency departments and oncology clinics for now will continue to be masked. There are some questions with what does that mean for radiation oncology? Is that considered a cancer unit? And well, each of those individual areas that take care of some cancer patients and what they should do, we'll deal with those at the local entity. But masks are optional, but encouraged throughout the healthcare system now. And that caregivers that had an exemption will remove the mandatory testing for them that was occurring as well. And we would anticipate, if it hasn't been announced already, that we will not mandate COVID vaccines because that looks like where the federal government is going. And people have asked, does that mean the people that were terminated for not being vaccinated could come back? Yes, but we will still have an influenza vaccine mandate. So that's not going away. If you get a respiratory illness, just report that to Employee Health Service and they will walk you through what you should do in that situation. So somewhere back to normalcy or getting close to normalcy here as the summer comes up, which we're all excited about, I think. So other than COVID, what's going on in the healthcare system? And I keep on going back to the Charles Dickens, The Tale of Two Cities. So, it's kind of the best of times and the worst of times, the age of wisdom and the age of foolishness. And there's so many good things going on, but yet I have so many stress operations because of staffing shortages and just a high demand for a service. It seems like every week I'm getting some glass statue in the mail for some excellence award in this or other things, and U.S. News and World Report or the Lown Institute in terms of how we do as a safety net healthcare provider and how well we support our community. And really, the accolades are coming more and more for things like our Food is Medicine program and helping with community work, which we've really put an emphasis on in the last strategic plan, and getting us national attention. And that's all wonderful, and I love the awards, and I love the national attention and the positive articles in the newspaper. But fundamentally, what our core operations are so stressed. If you look at the inpatient side, we can't get patients out of our hospitals because there's no nursing home beds. There's a shortage of skilled nursing facilities, especially if a patient is on mass health. I looked at some numbers yesterday that for long-term care, if you're a Medicaid beneficiary, we make over 100 referrals for every one patient that they'll accept if you're on Medicaid, which is just ridiculous and wrong that they're allowed to do that. And so those patients sit in your hospitals and sit in Marlborough Hospital, cause a backup into the emergency department. And last time I was down there, you're seeing patients in the former waiting room or a portion of the former waiting room because you're so backed up. And it also has a very negative effect on the finances of the organization because all these extra areas that we're staffing, we have to staff with contract labor, which is very, very expensive. Somehow, some way, Marlborough Hospital has stayed on budget and has a small operating surplus, but that's doing much better than the rest of the healthcare system. So we're seeing record inpatient volume, outpatient volume, and that's not a big piece for Marlborough, is up 10% from 2019, up to 1.5 million visits a year now. But that we're doing that with about 10% less people than we had before because of the vacancy rate. Record revenue, record expenses, record vacancies. So the core operations, especially at the medical center, are losing money despite being incredibly busy. We really did make some progress in closing the gap. We had a vigorous venture strategy over the last several years that have helped us keep cash high. And so we still have money to invest, hopefully in the Marlborough physical plant soon. Steve's going to be talking about that with our board and next week, the week after at a board meeting and trying to look at what some of the facility upgrades we want to do to Marlborough. But we've got to get the core operations back on track. So we're fighting the commercial payers hard for better rates, just demanding rates that we haven't demanded for a long time. We're working to decrease the travelers, filling the vacancies, grow some areas that are profitable, trying to reorganize how we do behavioral health. Marlborough does a great job with it. It's not been a focus of this. Benchmarking all of our corporate services to see if there's any opportunity to take costs out there. And, the supply chain, length of stay reductions, that's every year that you're in healthcare, you're trying to do that. And then each entity has an individual improvement plan, including Marlborough. And again, I don't know if it's good or bad, but Marlborough is the lowest maintenance, to say, in terms of attention right now from the CEO's office of all of our entities. So hats off to all of you for your great work there. There's a lot more going on in the healthcare system. I'd be happy to, if I don't know what's mostly of interest to the folks on the line. And Steve, you can tell me, you want me to take questions at the end, or do you want me to take questions now?
We can open up for questions now. So far, we just have one about the dates on the first slide, but I think that's just an entry on, it says 24 on the first slide, but we'll fix that. Does anybody, if anybody has any questions, they can feel free to put them in the chat window. We haven't seen any come in, Dr. Dickson.
All right, well, I'll just hang out with you and I'll let you move on with your town hall. And if anything comes up, we'll address it at the end.
Sounds great.
And I didn't get the memo about the blue shirts. Sorry, guys, I would have been there for you.
It's all we have. We're not allowed to have colors here, so we'll work it out. So I'm going to turn it over to John, who's going to walk us through some of the current quality, and then turn it over to Mike, who's going to talk through some of our HR pieces.
So, all right, hello again. So this is our quality scorecard for the month. It has our metrics that we work on. So some of these lag a little bit more than others, but the inpatient mortality was 0.59 for the month. We're a little bit behind for a year to date, but we are making up some ground. And we had a rough couple months, November, December, but I anticipate that with the continued work, we'll get there on track. Next one up is really patient harm events, 0 in the month of February. 30-day readmissions is reported back for January at 10.1, which is where we are for the year as well. And then willingness to recommend, we're going to skip this one because I have a more updated slide that is far more favorable than this score right here. Steve, can you just click back in the, there we go. So this is our current inpatient recommended hospital for HCAHPS. And as you can see, starting in September, October of this year, we were, of this fiscal year, we had kind of a rough start, and then we've kind of continued to improve. And a lot of it was really around, when we looked at the data and everything was around the volume, that we had the emergency department and then all of the, the boarders and the patients just waiting so long to get upstairs, and all of the, our smaller rooms being used as double rooms all the time. But as things have kind of eased back, we've made some good improvements with our patient experience. We've also implemented some additional things, Sinead and her work around the cipher rounding and getting us out there and rounding on the patients. So we do have some improvement, and we're going to keep working towards that and end the year above where we did previous years. Falls month to date, I just put this out there because this is an important metric, and this is every fall that happens. So it's a lot of falls because this isn't what you would see kind of reported at a state level, or if you went online to look. This is every fall that happens anywhere in the hospital. So April, great job for the emergency department, 0 falls. We're continuing to have some falls in med surge, but there is lots of work that's been done up there, including the new bed alarm systems, and that get rid of the user error and which plug you depend on it. The 2 falls there were pain, so those are counted as injury, but nothing of any significance. Granger 3, and then just a total of 7. So a better month than we've had, but we're continuing to work on that. So thank you, but I do bring that to everyone's attention because falls we want to make sure that we avoid any significant fall with injury. Here's the ED scorecard. It's a little busy, but we'll send this out so you can look at it. But I just need to move this box right here so I see the totals. But As you can see, our volume in the emergency department has been kind of continually growing and has been strong now. We're stronger now than we were pre-COVID, and you know, if you kind of on our annualized data, we're over 30,000 visits, which is the most it's ever been in the 9 years I've been here. And you know, our pediatric volume, which had died down for a while, is back. Well, our admission percentage is still about the rate. But one of the other kind of things you can look at you know, where you see boarding hours, our boarding hours have come down significantly. And I mentioned that a little while ago that, you know, starting in September, we were, you know, over 2,000 boarding hours, and then even October, November, and then back up again in December, January. That many boarding hours is just unsustainable for us, and it, you know, has a huge impact overall on what's happening and from just a congestion and a flow perspective. But we'd like to see it back down around less than 500, ideally around 200 to 300 hours a month. And those are just kind of the operational movements of patients, but we're making progress, and so great job there. And last one there, sorry about that, is just the door to provider and left without being seen. As you can see, the Dr. Costigan and the rest of her team and Lane are working closely to get patients in the emergency department and getting them out, and making sure that our left with being seen is you know, decreasing. Ideally, it should be below 2%, and you know, prior to COVID, that's kind of where we were. But we've had some bad months, as you can see. So being right back around 3% is not so bad. Along with that, you can see the immense improvement as things have calmed down there with the likelihood of recommending the emergency department. So great work by Lane and her team and Dr. Costigan. I'm going to hand it over to Mike Pruda to talk about HR updates.
Good afternoon, everybody. Dr. Dickson, welcome. So we're just going to quickly touch on a couple HR items of the 8 hires and separations for this past cycle. A friendly reminder on our AREs that we all need to do, and just also another reminder on the referral bonus programs that we have. Oops, sorry. So this is the hires and separations for the whole system. So as you can see, we track this on a monthly basis. So for the system, the goal is to hire 202 external hires in the month. A little bit short on that target, 168 out of the 202. But also in the second grouping, you'll see that we also track the separation. So you want to hire as many people and have as few separations as possible, so you have a positive delta every month. So you can see for the system, 38 positive for the prior month, the month of April. Here at Marlborough, a little bit in the red. For external hires this past month, our target was 12.5, 12 or 13 people, and we only were able to hire 5 external candidates, so we were short on the goal. The good news is we were also short on our target for separation, so we want that to be as close to 0 as possible. The monthly target, 10.7, and that was 6 for the month. So just so you know, we are doubling down on work with the TA team. Kate Erlab and Mark Beeson's team are working with us to drive the amount of external hires up to all of their innovations through talent acquisition. The next one is the annual required education. So we all do this every year. This is a Joint Commission requirement, also a policy requirement of Marlborough Hospital. And there are a couple things to just remind everyone on. I told the management team already, or informed the management team at our meeting last week, but just a few things. We have a new one, EVADE. That is a Joint Commission requirement. That is our training for safety for all caregivers. Some caregivers who were very early to adopt this program actually completed them before January of 23. If they did, then they will need to do them again. I'm sure they'll do very well in the course. They'll complete those for 2023. Okay, so that'll be in everyone's e-learning for you. That's just a reminder that we all have to do that. And one other thing that folks didn't see last year, and now it's going to come back, there's a wage and hour module that's by the state of Massachusetts regulations that we need to just share that with everyone so they can see the wage and hour laws here in Massachusetts. So both our managers and all caregivers need to see that this year, 2023. It'll be off for 24 and then be back again in 25. And then another innovation, and also just to make it easier for us to accomplish this task, these trainings, is to allow people, if it can't be completed on the work site, that they do have the ability to complete them off-site. They will be paid because this is mandatory training, and they just need to follow all the procedures that are outlined on the hub. Yeah, the caregiver engages with their manager, the manager approves it, and then we can just track the time that they spent completing the ARE, and then they're paid accordingly. And the rest of this is just additional reminders about ARE for this upcoming year. One of the things we're also saying is don't skip right through to the end. If you just look at the instructions, sometimes if you see in the top tip, it also helps for you to complete the education training in a faster way. And you still do need to look at all this because, again, it's a mandatory training and education for all of us. So that is it. Oh, I had the referral bonus program. Don't forget, the slide's not here, but the referral bonus program is very active, and that's a way that you, current caregivers, can encourage your friends, family, and other colleagues who work in healthcare to come submit an application to Marlborough Hospital, hopefully, or to UMass. We'd love for them to work, and when we hire them and they're permanently brought onto the payroll, then 3 to 6 months later, assuming they stay with us, then you'll receive your referral bonus, and that referral bonus can go up to $5,000. So please consider referring your friends and family for us to hire at UMass and at Marlborough Hospital. Thanks.
Yeah, so just to add a little bit to the one thing that Mike jumped over there is, for any caregiver who was hired before 2020, there is a lot of information out there. You will need to go back into the system and submit a W-4. This is a federal tax change that's going on throughout, so we need to have an updated format for that. And please go in and look at it, and when you make the changes or resubmit, what you want to do is make sure you check your paycheck every week to make sure that you didn't make any entry errors, because that will be your go-forward W-4 into the next tax year. So it's very important for you to check that. And I know there's some process cheat sheets that are on the hub for you to go in and do that, which is very easy to do. So, all right, so I'm going to jump in just a little bit about the volume through the month of April and year to date. On the inpatient side, both the acute and the OBS combined discharges were up in the month of April. Psych days are also up, mainly due to some longer stay patients, which is okay. As John did talk about, you can see our ER volumes. We're running about 8.5% higher than our budget, and slightly down to prior year in this month only. The OR has been relatively busy, and the endoscopy colorectal area has been very busy, at least in the month of April. When we move down to the year-to-date, as you can see, our observation numbers are way up. We're up 17% to budget and 22% to prior year, and the acute inpatient discharges are up 3.5% to prior year. So overall, strong inpatient year so far. What's really important here is our ER visits that John talked about. We're running about 7% over prior year at this point. That's a pretty strong run. The OR volumes are down slightly compared to prior year, and endoscopies up almost 20%. So we do have a lot of patients who are in the queue for care and continuation on that. So we are actually in the process of evaluating an expansion in Southborough to bring in 2 additional endoscopy suites, and hopefully we'll be starting that project sometime late summer. I want to just give you some idea of our financials and where we are currently sitting. I will say year to date we've done pretty good, but that is also buoyed by about $2 million of one-time funding from the state. We got about $1.9 million in November. So we're slightly below zero, unfortunately, but that's kind of where we're sitting right now on the operating profit line. So in the month of April, we did have a little bit of a challenge, and I'll go through some of those issues that we faced. The good news is on our patient service revenue was very strong, as you can see from our volumes being high. We had some good performance there. We did have unfortunate impact of free care HISNO. We're going to probably experience this over the next few months. There is a Medicaid redetermination process going on, and we are seeing more patients flow into that category. So we did have a negative $200,000 hit to that. And then on the other operating revenue, we did take a pause on recognizing some of our Medicaid waiver funds that were coming in. That will hopefully get rectified in the month of May, and we'll see some improvement there. But we just want to take a pause to make sure we were reporting those correctly. As you can see to the right, we're about $1 million higher overall on the other operating line. So that's where the money's coming in through that, as well as some of the state funding. On the expense side, John did talk about it. Our salaries, wages, and agencies up significantly. We're up $500,000, and Dr. Dickson really put the pressure on this. We have seen a continued challenge on hiring here, which means we've been relying a little bit more on agency over the last 3-4 months, and that impact is starting to hit the P&L pretty significantly. I believe we spent almost $800,000 this month, so it's not great, but we're working through the improvements there. And then because it is a quarter end, being April, we did have some settlements with some of our physician providers, which resulted in some impact on both professional fees and the purchase service on the affiliates. So when you get down to the bottom, we're about $900,000 over on our operating spend for the month, which did have a negative impact. We lost just over $1 million in the month of April compared to a plan of $365. The good part is we get some MSF and MES, which brings it back down under $1 million. But on a year-to-date, bottom line, we are sitting today with a $2.7 million surplus. About 1.9 of that is coming from one-time fees and revenues from the state, which is significantly better than the prior year loss of over $9 million at this point. So, as Dr. Dickson said, Marlborough is doing a pretty good job maintaining. Certainly, we don't want to have too many more Aprils on the books, but we will continue to monitor that and move forward through the year. But overall, we think everybody here is doing a pretty good job, and we're managing things as we go forward. So I'm going to stop sharing the slides, and then we do have some, well, we don't have any questions that have come in so far. Are there any questions or thoughts that anybody would like to have an answer to today? And we'll stay on. Please put them in the chat window. It's hard to unmute everybody and get it because we get tons of background. So we'll hang around for a few minutes, and if you can put the questions in the chat window, we'll answer it for you. Otherwise, if you don't have any and you don't want to stay on, we appreciate all that you do for Marlborough Hospital and the communities and the patients that we serve. And obviously, we're here at any point. You can always email, call us, and we'll talk to you at any point. And we just want to thank you for all your efforts this year so far.
All right, I'm not seeing anything, Steve, so I'm going to break.
All right.
Get
Eric,
to my next exciting meeting. There's a question related to falls. Yeah, I'll let you address that.
Yeah, we'll answer that one. We're good at this one. And yes, Melanie. Sometimes have a good day, Eric. Sometimes they are legitimate. We do dig into them, but we know the majority of falls on Granger 3 are behavior related. But the way the method works is anytime a patient touches the floor, even if we the staff lower them to the floor, it counts as a fall. It doesn't mean it's a bad thing. It's just a way to track patients more appropriately. All right, so you're welcome, Melanie. Not seeing any other questions come in. We just want to say thank you, and we hope you all have a great long weekend and enjoy the weather. It's supposed to be nice the rest of this week and going through the weekend, and then next week's supposed to be in the 80s. So all things are looking good. Have a great day, everybody.